Good evening, everyone, and welcome. Thanks so much for joining us for this UMiami virtual health talk, Advancing Joint Replacement, New Technologies Enhancing Patient Care and Recovery. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by UHealth's Department of Orthopedics. It's a beautiful night in South Florida, no storms and no, or at least lower humidity. The surgeons at UHealth Orthopedics are experts in their field, exclusively performing thousands of primary and complex joint replacements every year. Using the most advanced joint replacement approaches available, our experts deliver superior patient outcomes. Our innovative treatment options help you recover faster, experience less post-surgical pain, regain bone and joint function, and enjoy a better quality of life for the long term. These advancements include the use of computer-assisted robotic procedures to replace knees, hips, and shoulders in a minimally invasive approach, resulting in a more precise alignment of joint prosthesis and, of course, a faster, less painful recovery. We're also the first hospital in Florida to use mixed reality, MR, and augmented reality, AR, for hip replacement surgery. MR has been proven to improve accuracy, leading to shorter recovery times. So we invite you to learn more about UHealth's orthopedic department by visiting umiamihealth.org/joint. And to schedule a consultation, call 305-243-3000. Don't worry, we'll bring that screen up again toward the end of our talk. You can take a picture of the screen and you can catch on again. So tonight, our esteemed expert will discuss the latest advancements in total joint replacement at UHealth, which includes robotic-assisted surgeries, augmented reality for increased precision, advanced materials designed for durability and comfort, use of wearable devices to improve recovery, anterior hip replacement. Now, that's a technique that affords less cutting and optimal recovery. And at the end of the presentation, there's going to be a Q&A session, which is a unique opportunity for you to ask direct questions of our expert tonight. So make sure you take advantage. Use the Q&A feature at the bottom of your Zoom screen to enter your questions. We'll prep them up for our expert. So now it's my pleasure to introduce our speaker, Victor H. Hernandez, the Chief of Adult Joint Reconstruction in the Division of Orthopedics at the University of Miami Health System. He's also a clinical professor at the University of Miami Miller School of Medicine. Dr. Hernandez has extensively trained in hip and knee joint reconstruction, including, as we said, anterior hip approach, muscle sparing techniques, bilateral simultaneous knee replacement and complex revision, as well as patellofemoral and unicompartmental arthroplasty. His research focuses on patient outcomes, technology, disparities, and cost-effectiveness analysis after joint reconstruction. Dr. Hernandez has contributed over 60 original peer-reviewed scientific articles to medical literature and has won multiple awards and, of course, recognitions due to his outstanding scientific contribution to the Orthopedic Association. His research has been showcased in regional, national, and international orthopedic scientific meetings on over 300 occasions. Let's welcome our superstar tonight, Dr. Hernandez. Take it away. Make sure you are unmuted and ready with your presentation.
Hi, thank you so much, Ileana, for the nice presentation. Let me share my screen. Okay, as everybody knows, everything in life has evolved. And knee replacement and joint replacement and shoulder replacement also has evolved. Today we have in an iPhone or a phone, we have computer, GPS, and different access to multiple different tools. Why we need more technology in joint replacement? It's still in joint replacement, like hip replacement and knee replacement. Hip replacement is still 2.5 a risk of dislocation. Leg discrepancy is still an issue in joint replacement. Most of the patients complain after the hip replacement that they are short or long after the surgery. Femoral fixation and the need to go back and revise a hip replacement is still an issue. And a lot of muscles and tendonitis around the hip replacement is still an issue. In terms of the hip replacement, first, when we started doing knee replacement, we were trying to consider that pain was the main cause. And we asked a lot of the patients to wait as long as possible to just relieve the pain. But with the time and the new technology, we have seen that the longevity, durability, function, satisfaction has become one of the main factors to require a knee replacement. And we want our patients to feel like a hip replacement, that they have what we call a forgotten joint or a normal knee, to the point that they can return to do whatever they want in life. So how technology has improved in the past 10 years in joint replacement? There has been several improvements not only on the preoperative, but the intraoperative and the postoperative time. In the operative, we have changed since COVID to go into more virtual and computerized visits before the surgery, and time is money for all of our patients. So we have a lot of patients that not only live in Miami, but they live in Central Florida or outside. My practice actually is around 20% of international patients who just come to do the surgery here at UM. And for them, it's a lot of time and money if they just come to see me and see the physicians and the anesthesia team. So if you see this study from Amwell, which is one of our insurance, you can see that a telemedicine visit for a patient can cost just only $5. But if you see that same patient in an in-person patient, it can be $43. And as I say, we have a lot of patients who travels to UHealth to get the care. So how we can change that? We have changed our preoperative class to an in-person class. We have created the Incision Academy, where we have seen patients and we provide virtual care of those patients. So we see the patients not only on a telemedicine visit, but in person if they want to come. And then after when we schedule the patients for surgery, we can provide a lot of educational tools through the telemedicine visits. If the patient has more questions, my team will be more than happy to access those questions. We can talk to family members who doesn't live in Miami and their concerns about the recovery, how they will recover, and we can access to them through telemedicine. Preoperative optimizations, I have the blessed to have Dr. Delgado and Dr. Osman. Dr. Delgado is one of our cardiologists at UM who can work with your personal physician, either a PPC or a primary care physician, or if you're out of the United States, it also provides some care working with physicians outside the United States. Brian is my chief of joint replacement, and he will go over and optimize your patients toward the surgery. Like, for example, there's patients who has diabetes, malnutrition, high BMI, anemia, HIV before surgery, and we can work these patients. Joint replacement today is not urgent surgery, and this is something I want to bring to do today. We can do a lot of things before getting into surgery. When you need a hip or a knee or a shoulder replacement, it's been more than 10 years that you've been suffering. So there's not an urgency to get into surgery. And we can do a lot of things to optimize if you're not a perfect candidate to come out with an outcome that we all want to do it. We also, every single patient in our practice get preoperative assessment in terms of pros and cons, which is patient-oriented outcomes. So we research all of our patients, and we can see for the past 5 years how our patients are doing. So in our practice, we can provide you with a very detailed how much complications we have, how much infections rates, how much dislocations rates in our particular practice. And we can follow you how successful you can be in your surgery. This also helps us to do research in terms of how can we improve in the future on our population and make it better. We have published several articles in the orthopedic literature to make this joint replacement better. Intraoperative at UHealth, we have, for each one of you, we have a very specific plan. Every patient is a different patient. You come to our surgery. We have, as you can see on the picture, you can have what we call valgus, varus, or neutral knees. So you can live all your life in a way that your knees were towards the outside or towards the inside, both legs. And we don't want to change those patients that have lived all the way. How we can do that? We have changed our way that we see. We use nowadays something we call kinematics alignment, and that allows to do a three-dimensional evaluation of your anatomy instead of doing a two-dimensional with x-rays. How we can do that? With use of technology. At the UHealth, we have robotics, all kind of robotics that you can access as today in the market. And we can be very precise in terms of the cuts and alignment that we can do on our patients. So it's not only pre-operative that we can plan for these cases, but also intraoperative, like you can see. This is actually during surgery. We can actually see how your kinematics or motion is during surgery, and we can plan for different type of or different trials to see if you have a perfect alignment and a perfect motion before and after the surgery. So we can make little adjustment. For revision cases, I know a lot of the participants today send questions about revision, how we can use technology in revisions. So we also have access to this kind of technology to improve the alignment and the stability of knees and hip replacement. On the hip replacement, also we can use all this technology to pre-plan before the surgery. So I can take your images before surgery and go over of them and see what is exactly will be your size of for a hip replacement or a knee replacement. And then we also have access to augmented reality. Augmented reality is a new technology that can help us planning and seamless going through a joint replacement, like you see on these pictures. We can go over the CT scan. So before the surgery, we took a CT scan. I can actually go and do virtual surgery on you and then plan exactly how I'm going to position my components to decrease the risk of dislocations and complications during surgery. And this is a little example with the virtual reality. I can actually impose how you actual bone is within your body, and I don't need to do a big incision to be able to see the bones and the position of the components. So this is a technology that I think is going to change the future of orthopedics. And we at we do have access, and we're developing this technology. The intraoperative, not only sometimes when you have a lot of osteoporosis, we cannot depend on your bone, but we have to put screws. And we can use this technology to see exactly how long will be the screws that we use on you and where is the trajectory of this bone. And then we can compare what we are planning to exactly where we are done after the surgery. We are the first institution that actually are publishing the first 50 cases done using this technology. So we are ahead of everybody, and we know exactly how to do it. Post-operative, there's also technology that we can use. This week, we just opened our first live skills gym and joint replacement dedicated floor that is unique in Florida for joint replacement recovery. So our patients that have either they can go home the same day or they go home within a week or within a day or two, they can go to a specific floor where we have is like a small house that you can go and do what you have at home: stairs, bed, bathroom. If you have a bathtub, we can train with OT and PT on how to get into the bathroom, how to get into the toilet, how to climb stairs, how not to get into a car or go after the car. We provide patients after surgery with a very specific multimodal pain management, trying to avoid the use of narcotics and see if that patients can recover. Based on our research, we can most of our patients with hips or knee replacement can return to drive within 2 or 3 weeks. For a hip replacement, normally the patients can return within a month after surgery. And with a knee replacement, they can return around 6 to 8 weeks after knee replacement. And then just to finish, how the postoperative care has changed and how we are providing the health community on how the patients needs to recover. We developed this a wearable device. So in orthopedic, wearable device has been very behind compared to other medical fields, like, for example, cardiology and neurology, as well as endocrinology, has for diabetes wearable device that you can use to control your glucose levels and heart rate and blood pressures levels. But in orthopedics, we have become a little behind. So since 2014, I started working with this device, which is basically, if most of you people are familiar with the Apple Watch that has gyroscopy and accelerometer, we can actually, with those little two devices that we apply after surgery, we can measure how you perform after surgery. And you can do exercise, and I can actually, on a daily basis, can see how you are doing your range of motion, your exercise, and I can exactly guide you how to do it. So the patient in the app is actually able to see where I want that patient to go, and he can do the exercise, and I can guide them if they're doing a good exercise or not. Through the app, I'm able to see how the range of motion, skin temperature, if you're having fevers or not, for any questions about infections after surgery, the pain, if you're having high pain scores that we don't expect it, you can send me texts, you can send me messages, and I can see how your wound is. I can see how you're doing the exercise and how compliant are you with the exercise. I'm going to show you a couple of examples after a knee replacement. These patients were having really decreased range of motion. We contact the patient, and it shows the patient had a lot of pillows before the surgery, which is not good after surgery. We try to work with the patient, so we establish every week a different type of frame time in terms of goals for the surgery. We changed the multimodal pain management, and you can see how the patients progressively did well. These all data, our group is the first group in the USA to publish data about how the patient needs to recover after surgery, and we have described how values needs to be after surgery. And through these device, we have been able to say, okay, my patients will recover in around 50 days of recovery, but there are some patients that goes really low or no compliance that we can call and say, hey, you're a little behind of recovery. Why don't we work a little more with physical therapy? And there's some patients that we call the overachiever patients that they go really crazy about recovery, and then they crash, and they have to come back and recover, and they crash and recover, and they don't do that well. So we can guide not only the patients that are behind, but also the patients that are ahead, that we are afraid that they're doing a lot of more exercise or more pressures on their knees or hips that they need to be doing. Now we're working in terms of the hip replacement to develop this also for hip replacement, as well as shoulder and spine surgery. So this is pretty much all the new technology. I'm more than open to answer some of the questions. So Eileen, if you have some questions, more than happy to answer.
Thank you, Dr. Hernandez. A great course in beginning to end of how you handle patients. So yes, perfect time to transition to our Q&A session, which we're going to launch now. We have a lot of time. This is a 1 hour webinar, so a lot of people have questions, and we already had some that were brought in before that were submitted. So let me begin with this one, which I think is a very key question that a lot of patients ask. And that is, what materials are used for joint replacement prosthesis, and how long will these artificial joints last? Because I think people worry, am I too young to have it? What's the right age? So let's go into that.
Yeah, so before we have to, around 10 years ago, we didn't have the materials that we have today. And we used to ask the patients to wait as long as possible for a hip or a knee or a shoulder replacement. Today, we have various materials. Some of the hip replacement and the knee replacement that we have today is what we call cementless, which is made of titanium, and is the outside of this is made out of 3D printed. The 3D printed is pretty similar to the bone, and the bone get confused and grow within the prosthesis. So when they grow, this is forever. The only part that you will wear is going to be the plastic that is in between the components, either for a hip replacement or a knee replacement. So normally the plastic that we have today should last in between 20 to 30 years, and it depends on the age, and it depends on the activities, and it depends on the weight that you put on it. It's like I always tell my patients, it's like a tire from a car. The knees and the hips are the tire of your car. The more miles you put on it, the more weight you put on it, the faster they're going to wear off.
Yeah. So how long have these materials now been in use? For someone who had a replacement 5 years ago, was that material used or no?
In my practice, I've been using for the past 10 years. So within 10 years is the new materials has been used. But there's a lot of practice that hasn't changed into the cementless knee now, that it could be a little longer, less.
So these are the people who would potentially come to you for those revisions or for those changes of joints. Yeah. So let's talk about patients over the age of 70 then. Pros and cons. I mean, are there alternatives to having a joint replacement?
So joint replacement, when patients come to me and say, hey, Dr. Hernandez, I need a joint replacement, I say, this is not a question for me. This is a question more from you. So joint replacement is not an emergency or something that you need to go into it right away because there's nothing we can do about to save your knee or your hip. This is a question for the patient. When you feel you're losing independency, you're losing mobility, is the time that you may need a knee replacement. When you felt all conservative or non-surgical treatment like injections, physical therapy, and you feel is affecting your quality of life, it's a good option. Joint replacement is within the all options in the long term, is the only options we have in medicine that provide more than 15 or 20 years of relief. But it's a surgery, as I say to all my patients, it has some risks and benefits. Most of the risks, if it's controlled and optimized toward the surgery, are going to be very minimal, less than 1%. But it's still a surgery. So most of our patients go around 65 years old is kind of the best time for you to get a hip or a knee replacement.
So let's now talk about the surgery. I know that you all consider it outpatient surgery, but is there general anesthesia? What are all the steps involved?
So for today, we are doing same-day discharge. So patients can go home within 6 or 8 hours after surgery. And some of the patients stayed overnight just because they have social situations that doesn't allow them. But knee and hip replacement has become an outpatient surgery. So we use spinal anesthesia, which is pretty much like an epidural anesthesia, where patients can walk within 3 hours after surgery. We try to avoid general anesthesia for several reasons and increase complications risk for the surgery. But most of the patients, 95% of my patients, they just have spinal anesthesia and they get sleep. So they're not going to hear or they're not going to feel anything during surgery because they're going to sleep. They're going to feel the sleep. It's pretty similar when you go for a colonoscopy or similar procedure.
Right. Because I know that people are concerned listening to this, you know, how extensive a surgery is and so forth. And I know that the people in our Q&A box continue to enter questions, and we do have a great staff. Dr. Hernandez's people are helping to answer some of those questions directly. So some of them will do live and some you'll just get your direct answer. So let's continue on with the other questions we already had. What are the steps for a successful recovery for knee replacement? What is recovery like?
So recovery in our population, it takes around 50 days, around six weeks. Most of the recovery is done pre-operative. So patients that are overweight, we try to get them in a good situation, either with our weight loss program that we have at People that are smokers, we have a program at for smoking cessation that we can involve them within the program. We have multiple teams from endocrinology for people that has thyroid problems, people that has osteoporosis, to try to get them better into the surgery. As I say, this is a surgery that's very elective, but it's a surgery that if you're success, it's going to be for 25 or 30 years. But if there's any complications, can be a very severe complications like infections, DVTs, or thrombus. So the main recovery or the main issue the patient had is going to be before surgery. And that's why we use all of our resources before the surgery to get the patient optimized towards great success.
Yes, I found that interesting, Dr. Hernandez. So Dr. Delgado, your colleague over there, who does, a lot of the cardiovascular and cardiology. So you're basically looking at the patient. It's not just about the joint. It's not just about your knee. It's your total health. It's a very multidisciplinary approach, would you say?
Yes, that is correct. So we have within we have the UPAC service, which is our anesthesia team, and we have all multiple departments that can get involved. For patients that has revisions, a lot of them, they come as a referral center because we're a referral center for complex cases for infections. So we have a full team of infection doctors that can take care of you, as well as our team of orthopedics. So these cases that, sadly enough, the knee replacement or the hip replacement didn't went from the right way and ended up being infected or dislocations, we have a full team that is ready to take care of you.
What is your rate of revisions and also your rate of infection?
So that's a great question. We do have, we actually measure every single patient who come into our practice. For infection rates, we have one of the lowest revision rates. We have less than 0.5% in terms of revisions. In terms of complications like DVTs, thrombus, we have around 1%, but it's very low compared to the national benchmark, which is around 3 to 5%.
Scary that it is that high. So bravo to us. Let's talk about knee osteoarthritis. What are the new treatments or options? Or can joint replacement just be the answer to treating osteoarthritis of the knee?
Yeah, for knee osteoarthritis, it has a lot of things to involve. And UHealth has done a lot of research in terms of define what is the genetics. We have multiple teams that are working with genetics research in terms of seeing there's a marker for genetics that we can change before the people has osteoarthritis. But by the time you have osteoarthritis or degenerative disease of your joints, it's a little too late. So most of the treatment we have today is just for conservative treatments. So we start with the most important part will be to have weight loss and exercise. Weight loss because for the knee or the hip joint, for the knee, it's around 6 pounds. Every pound you lost, it's going to represent 6 pounds of pressure on your knee because of the area of the knee. It's a small area for your whole body. So every pound you lost is around 6 pounds or 3 or 4 pounds for the hip. And then the other part that is important is to recreate muscles. So muscles will support your joints. So, and that's why some of the people that comes to my clinics, the first option is try to lose some weight and do some physical therapy and learn the exercise to build muscles around your joints so you can take some of the pressure out of your joints. And then after losing weight and having some muscle recovery from physical therapy, we can start with injections. So there's multiple injections today that goes from steroids injections to viscosupplementation injections, which is hyaluronic acid, to PRP, to stem cells. Some of them are in research like stem cells. PRP has shown some data, but most of the insurance doesn't cover. But viscosupplementations and steroid injections has shown some improvement in the short term. So if there's a patient that has multiple problems and this is not a good candidate, we also have other options with our pain management team, which includes Iovera, which is a cryotherapy. So we can frozen the nerves that goes into your joint and cause pain. And we can do something that is called radiofrequency ablation, which is burn your nerves that goes around your knee and actually will decrease the pain for up to a year. And this is done pretty much on an outpatient basis. So there's multiple ways to decrease the pain and the discomfort that you have, even if you're not a candidate for a knee or a hip replacement.
Yeah, so there's a way to soothe the pain, without having to jump to the final level. Let's talk about what you were saying about quality of life. So let's say somebody has an MCL tear, an ACL tear, they've had it for a while. And I know there are levels of severity. There's one in which you lose complete lateral movement and you can fall. And I guess that's the extreme when you need it. But if you're, let's say, because I'm watching some of the questions come over, 65-year-old person, and you have this MCL tear, but you're still living with it. Do you hold off before you say, I need a total knee?
It depends how bad is your cartilage and the meniscus around the knee. So you can have an ACL or a PCL, a ligament injury, but if you have a good knee around, you don't need a knee replacement. You can go to our sports guys and have a reconstruction of the ACL and have excellent outcomes. But if you already have damage to the cartilage, you already have damage to the meniscus, you have previously, and most of the time when you're over 65, the main problem with arthritis is you lost a lot of water within the joint. So when you lost water, you lost a lot of the things within the joint, like the fluid, the meniscus, the ligaments, are made, most of them, out of water. So when you lose water, they become very stiff, and it's easy for you to break them. So you break the meniscus, you break the ligaments, and it's difficult for us just going into a knee scope to repair them, because every time we try to do a stitch or try to repair, there's a very stiff tissue, and then we break them. So most of the time, a knee scope for a patient that is over 65 for repair a meniscus, we don't repair them. We just kind of reshape them, and we take some of pieces out. So at that point, there's multiple other options surgically, like partial knee replacement, patellofemoral arthroplasty, or unicompartmental knees that we can do, and we can provide better outcomes instead of doing a knee scope.
That's, I'm sure, puts people's minds at ease. But the bottom line is, Dr. Hernandez, they have to get into the clinic. They have to have a scan. They have to have an MRI. Let's see how severe it is. And then you all decide the course of treatment.
Yes, exactly. There's multiple, today we have multiple images that we can do to make a great decision.
Okay. Let's talk about what we were talking about, the incision. So the difference between anterior and the bikini incision hip replacement, and how many surgeons are doing the bikini incision procedure, and talk about what you're doing.
Yeah, I know a lot of the patients is asking now about the bikini incision, I guess because we are in Miami and they want to wear the bikini. So anterior approach has become the new kind of mode. I've been doing anterior approach for the past 12 years. So it's not like a new approach that we have at We have been doing for the last 12 years. And the anterior approach can be done in two different ways. It can be done on the bikini incision, which normally it's a little easy for the patients to heal, but it's a little more complex for the surgeon to do. So you have to make sure your surgeon is comfortable when you ask for a bikini incision versus a regular anterior incision, because it can provide a little more complex into the case. We at we do have, all our surgeons can do bikini incision and anterior incision, but you have to be a good candidate for that. So on patients that really requested, we actually have a study on obese patients where we have shown, and we're going to publish probably within a year from now, that they do heal better. So it's a better incision, but sometimes when there's complications, you have to do a double incision. So it's a difficult for the surgeon to get out of with some complications like a fracture or something else.
I didn't see in your presentation that you showed exactly where those incisions are. So bikini literally just above the
Bikini incision, yes.
nickel.
It's just
Okay.
about, it's on the crescent line that you have on the inguinal line. So most of the time it heals without you see it. The regular incision is a little more at the bottom. And then there's three different ways to do hip replacement. It's the anterior approach, lateral approach, and posterior approaches. Posterior approach was the old way we used to do the incision. So on the posterior approach, it was easy for the surgeon, but more difficult for the patient because you cut muscles tendons. Lateral approach, you cut some of the muscles, and then you have repair, and there's some limitations. Anterior approach, you don't cut the muscles, you split them. So you work through the muscles, but does have a little more challenge for the surgeon itself. So the surgeon needs to be well trained in this type of approach because the complications can be a little more complex in terms of fracturing femur or having malposition of the components.
So now let's talk about, because you're talking about cutting and muscle and recovery and all that. Let's talk about the activities and the actions to avoid right after joint replacement. What's our time frame? I think you said it was somewhere in the neighborhood of a couple months, a few months.
Yeah, so for hip replacement is a quick recovery. So normally allow the patients to drive within 2 weeks, and most of the patients return to work within 4 weeks. So patients go into surgery, the same day of surgery, they're going to be walking, and if they're doing pretty well, they can go home the same day walking, putting full weight on their extremities. For knee replacement, it's pretty similar, but it's a little more long in terms of the recovery because they need a little more physical therapy. So patients with hip replacement recovery within 4 weeks. Patients with knee replacement can recover within 6 to 8 weeks. But this is the 80% of the recovery. After a hip or a knee replacement, you're going to continue recovering for the first year because we do a lot of work on the bones, but we don't work in muscles around. So most of the people who comes to the point that they need a hip or a knee replacement, they have a lot of atrophy of the muscles. So they have to recover this atrophy of the muscles in terms of physical therapy, recovery, and going back to life and do stuff that they knew. So we have seen that patients up to a year, 2 years after surgery, they keep improving.
How about activities or workouts? I happen to be a Pilates fanatic, and that's my workout. Is that a good way? Is walking? Is running? Is weightlifting? What are some of the ones you recommend?
So after surgery, we start with physical therapy and we guide to get the strength back, flexibility. A lot of the patient has lost flexibility before surgery, so we try to regain. In knee replacement, it's important that we don't allow the body to create a lot of scar tissue because it will decrease your range of motion after surgery. So it's important within the first 3 months to regain that motion. After 3 months, most of the patients return to normal life. I personally don't have any restrictions on patients. So they can return to do yoga, they can return to walk, they can return to run. And there's some patients who send me pictures about, I'm running this marathon, I'm running this. So and that's make me super happy because that's the goal of the surgery is to get patients back to what they like.
Yeah, sort of bionic parts,
Yeah.
Let's talk from bionic to robotic. What are patient requirements for those who qualify to have robotic surgery of hip or knee?
So we're blessed in UHealth that we have different type of robots. So some of the robotics, they require to have a CT scan before surgery, which today some of the insurance approves, some of the insurance doesn't approve. But we do have some other robots that you don't have to have a CT scan. We can actually get the points during surgery, so you don't have to have the CT scan. So in between the two of them, there's not much difference because the information is pretty similar. So in terms of robotics, we can use robotics in any single patient. There's no restrictions or some kind of contraindications to robotics nowadays.
Are the robots, I know we use different types, the Da Vinci comes to mind for different types of surgeries, but is it because it's more minimally invasive, done with the little hole incisions?
So it's more precise. And so you can make adjustment during surgery. You can actually check your cuts. You can actually check the balance. So the knees and the hips, it's similar to the tires of your car, as I said before. So when you go to Tiger and you say, hey, balance my cars, they measure exactly how much balancing and alignment your car has, because if one of the tires is lower than the other side, you're going to break. Eventually you're going to have some discrepancy and it's going to break. So it's very similar. And actually this technology has become from those ideas to make the legs pretty equal. So we can actually measure how much pressure you have in each side of the knee and balance the knee at the same way we balance our tires from our car to make sure you have a balanced knee and well aligned that you can use for 20, 25 years without a problem and without making or compromise your other joints.
Yeah, and the same thing I'm imagining with the hip. You got to make sure that it's perfectly aligned so that patient is balanced and their gait is normal.
Yeah, so one of the main problems with hip replacement is leg length discrepancy. Before we didn't, it was the surgeon like, oh, okay, this is pretty much the same length as the other leg. But we have a lot of problem. Up to 37% of the people after a hip replacement were uneven. So nowadays, with all this technology, we can actually be very precise in terms of, okay, this is going to be 1 millimeter, 2 millimeters, 3 millimeters, and then we can make adjustment during surgery to make it equal.
And once that patient is done and they have to come back for a revision, there's no way to adjust that hip imbalance unless you go back.
You're correct.
Yeah. All right, let's grab a bunch of questions now that we're getting bombarded by people who are totally listening. Let's see. Let's discuss the advantages and disadvantages of partial versus total knee replacement in terms of complications, recovery, and duration of the implant.
So partial versus total knee replacement, it depends where are you replacement. So not everyone is a candidate for a partial knee replacement, but partial knee replacement is a good option for patients that want to recover quicker and want to have at least 10 to 15 years of pain-free. So normally people that has on the knee, we have three compartments, the inside, the outside, and the kneecap. So if one of those compartments, for any reason, you have a previous trauma, you have a patella fracture, you have some kind of a previous knee scope that they took some of the meniscus out, you can have a very high advanced osteoarthritis on just one compartment. And with robotics and technology, we can replace that only compartment that can give you 10 to 15 years. But the difference between a partial versus total is recovery time. So a partial knee replacement, normally you will recover within 3 to 4 weeks. With a total knee replacement, you will have around 2 months to 3 months for full recovery. So with a partial knee replacement, people that are younger and only have one compartment, they say, hey, this is a good option because in 10, 15 years, I may be retired. And this is a good option for me to go back quickly to work or do my own stuff and continue having a normal knee. With the total knee, we replace pretty much everything. We replace ligaments, we replace all the knee. So it's a longer recovery, but in the long term, you're replacing all your knees. So you don't have a problem that eventually within 10 or 15 years, you're going to have. So as I say today, 25, 30 years after a knee replacement, you should have good outcomes.
Yeah. So I guess it depends on the patient, exactly as you say, the age, the activity level, and just how severe the joint is at the time you make that decision. How about somebody who needs two joint replacements at the same time? So simultaneously. How do you plan for that? One at a time?
It depends on the patient because there's multiple risk and there's multiple benefits of doing bilateral hips or knee replacement. I personally and my team also, they do a lot of bilateral hip replacement. In a day, we can do between 6 to 8 cases. So for the surgeon, it's not a problem to do both at the same time. But for the patient, it's different. And we have published, Dr. Dapuso, which is one of our partners, published a paper that won a national award about the complications of doing bilateral hips and knee replacement. And the main problem is that people does not have the double risk of having complications, but has 7 times higher the risk, including clots like DVTs and pulmonary embolisms, because it's more time of surgery and it's more time of the patient staying in the actual surgery. So when you come to see me or see one of my partners, we normally see if the patient has severe arthritis that has a lot of deformities that doesn't allow the patients to recover well if we don't do both hips or both knees at the same time. That's a patient that we say, okay, this is a good candidate, because if we correct one leg that is completely cropped and then the other leg is straight, it's going to be difficult for him to recover. So those are the patients that normally we bring into surgery and do both hips. But it's a regular patient. I will tell my patients, why don't you do one hip or one knee, and then within 6 weeks, the body, nutritionally speaking, will recover, and then we can bring you back, and it's safer for you to have a second hip or a second knee replaced. But sometimes patients have difficult situations by work or anything that they want to recover within that frame of period. And we discuss, and if the patient understand exactly the risks and benefits, we can come into an agreement.
Doctor, how about shoulder replacements? I mean, there was a time we never even discussed such a thing. And now I've known a couple of people who said, I just had my shoulder replaced. I'm like, what? That's where we're at in the 21st century, that it's that much simpler. What are the techniques involved?
Yeah, I think from after hip replacement, all joints has evolved to get better, because we have learned a lot from hip replacement in terms of materials and the surgical techniques. So today, shoulder replacement are very good. People can have not only shoulder replacement, there's a new, not new, but it's been several years, reverse shoulders. And I see a lot of people is asking about reverse shoulder replacement. So there's also ankle replacement that we provide. There's also wrist replacement. So we pretty much elbow replacement. We pretty much are replacing every joint. I think some of them is still not as long-term as the hip can do, but we have made huge advance in terms of outcomes. So for shoulder replacement, it's pretty similar to a hip or a knee replacement nowadays. So people that has shoulder problems, they can see one of our UHealth doctors. Dr. Munoz is amazing, and Dr. Galandia also doing shoulder replacement, and they can see if you require regular shoulder replacement versus reverse shoulder replacement. Normally, reverse shoulder replacement, you have to have several damage, fractures. Some of the muscles are not working to be a candidate for it. So it's the same as partial versus total. You have to be with your surgeon and discuss the benefits and the pros and the cons.
So a pretty extreme case of a shoulder problem with ligaments and tendons and you name it to get to that point, I'm assuming.
Yeah, if you're older, you have a lot of arthritis. All the replacement is the kind of the end goal of osteoarthritis. At the beginning, you can have in shoulder. The good benefit of shoulder is that the shoulder is not a weight-bearing surfaces. So you put pressure on your hips, you put pressure on your knees, you put pressure on your ankles. But on the shoulder, unless you're a worker that overhead and you're overusing your shoulders for work, it doesn't bother you that much as a hip or a knee. But there's options also before going into a shoulder replacement that pretty much like Dr. Kaplan or Dr. Braga can do. instead of repairing some ligaments, some injuries, some cleaning it off of the shoulder before considering a shoulder replacement.
And I know we talked about the robotic techniques, but another question that has just come on, what is the main difference between the robotic knee replacement and non-robotic knee replacement?
That's an excellent question, and that's a question we are discussing in our all academic meetings. It's like, is it worth or not worth? So I think personally, robotics bring a lot of precision into the game. So you can measure, you can see what you're seeing. Every time I teach my residents or teach people around the world, I say, if you don't measure, you can say if you're winning or not. It's like a scorecard. So if you don't have the score, you don't know if you're winning or not. So robotics will bring you the scorecard within the game. So when you're surgery, it depends a lot on the surgeon. Before, a good surgeon was an old surgeon that has done thousands of knee or hip replacement because he feels and say, okay, this is a good one because of your experience. But now with robotics, it short out that time of period and I put numbers on it. So I feel robotics has bring that into the game. In terms of long term, we haven't showed too much of a difference. Because if you're a good surgeon with a high volume, you should be able to perform good surgeries. But robotics in the long term, I think is going to eventually, when we have, robotics has been 10 years now. So we don't have the data in the terms of the long term. How will make a difference in terms of 30 or 25 years from now? So it's going to be interesting to look into the long term.
And I think it begs the question for you to explain a little bit more about how robotic surgery works. Because I think people are thinking, oh, it's AI, it's the robot that acts by itself. No, the surgeon is the guide. It's just that the instruments, the pincer that the robot has. So please take this opportunity to explain it better.
Yeah, exactly. So it's not that a robot is going to come into the room and I'm in my home just lay down and watching the robot doing the surgery. It's actually a tool. So it's a tool that make more precise. Like the robot I use, it's a blade that actually is an arm blade that I can cut, and the robot give me a feedback. So the robot will stop when the robot feels I'm not in the right place. So for the soft tissue, it will protect soft tissue. It will not allow me to cut stuff that I normally, if I'm old and I'm shaking, then I'm going to cut something else. But, and I actually can control the robot. So it's a dual feedback. And I say the different robot also will give you numbers that we don't have before. So if you say, oh, okay, I want to put this knee in 5 degrees on alignment, then you can have some tools that it tells you you're in 5 degrees. It's like a GPS from a car. It will guide you. It's like you can go from UHealth to your home because you know the streets. But if for any reason there's a hurricane like we just had, and block some of the streets and you don't know where to go, it's going to take you 2 to 3 hours to go back to your home. But with the robot, it's the same. So it's going to guide you to go faster and quicker. The other thing I always told my residents is the robot will make you consistent. So it doesn't matter. And we are all persons. All surgeons are regular persons. So surgeon can be your neighbor. A surgeon can be your friend. These surgeons can have troubles. And one day they come into surgery and they have a personal problem and they're not in a good mood. They're not going to perform the exactly same doing 8 cases in a day that they perform when they're in a good mood. So robotics will bring you every single time with the numbers, is going to bring you to the point that you perform equal every time you do the surgery. And we are actually measuring that. So we have right now, we have a study that we are measuring every single of our surgeons, how much physicality and how much mental fatigue they have during surgery. And we measure before and after surgery, and we can see how robotics can decrease that burden into the surgeon. So if you're a first case, second case, third, fourth, fifth case, you will have the same outcomes without having a problem with it.
Yeah, that's interesting. And I'm assuming that one of these replacement takes a couple of hours in the OR, give or take. Yeah.
Yeah.
So Dr. Hernandez is fascinating conversation, and I know that we could go forever, but if you could just sort of sum it up, how does UHealth stand out among the rest in South Florida? Because we have a lot of centers that are doing joint replacement. We certainly have great surgeons in the area. So, give us the final word as to why a patient would come to UHealth for this.
Yeah, I think, and it's not because we're UHealth. We train most of the surgeons who are in the South Florida area. They have trained with us. I have 100% confidence of all the surgeons that are outside that we have trained within the University of Miami. But at we have clinical trials. We measure everything that we do. We have access to technology that people doesn't have access to it, that we can take advantage and see if they work or not work. Most of our research has been quoted nationally and internationally because of an example of what we do here. And I think when you come to it's not only about research or residence or educational stuff, it's personal too. When you come to UHealth, if you can ask some of my patients that probably they're watching me, I provide pretty much 80% of my patients have my cell phone, so they can access me and become like a family, part of me. So joint replacement is not a single surgery, it's a surgery for life. And I will be for the rest of the life, and my team will be for the rest of the life within this joint to make them sure that they are doing the best that they can take advantage of the joint replacement.
Thank you so much, Dr. Hernandez. This has been wonderful. I hope I don't have to come to see you as a patient anytime soon, but we know if we need it. Thank you all for taking part in this conversation tonight. We invite you to visit umiamihealth.org/joint for more information. And of course, to schedule a consultation is 305-243-3000. And do us a favor, fill out the survey afterwards to suggest some other topics and give us some feedback. Our program is sadly come to an end, but we will do more of these. And Dr. Hernandez, you have a great night, everyone out there. Stay healthy, stay well, and thank God we didn't get a hurricane. Good night, folks.